Okay, students, we are now going to start on part 2 of our Unit 4 Maternal Newborn lecture. We left off the last time on part 1 with Parenthood slide. For me, that's slide 40. So we're starting on my slide 41. I don't know if your slides on Canvas are numbered or not, but this is the slide that says care of the newborn. So we left off with parenthood, where we talked about jealousy of siblings, jealousy of spouse, just relationships, family dynamics. Be sure you read that care plan on page 227, family care plan. So now we're going to discuss care of the newborn. And this unit, we are discussing care of the newborn, but we're referring to mostly right at delivery. So we're going to talk about resuscitation of the newborn and just how we care for the newborn right in the delivery room. So it's a lot different than if you're caring for a newborn 3 days later, or if you were taking care of a pediatric patient. There's some big differences that you're going to need to know about. So resuscitation for an adult has steps to it, as you know, like you are all certified in CPR. Resuscitation for newborns has its own algorithms, and for pediatric patients and adult patients, everyone has a specific algorithm for CPR. CPR for a newborn, brand new newborn in the delivery room is a little bit different. The steps are a little different. So, we go by airway, breathing, circulation always in CPR. Well, the key difference here in the delivery room is that the thermoregulation becomes the first step instead of airway. Okay, and that sounds funny, but the reason for that is because the baby has so much risk for being unregulated with their temperature that if they're not regulated with their temperature, they will immediately go into distress. Their respirations will bottom out. They will decline and need resuscitation. So the first thing you got to do is think about getting them warm. Now, this all happens very, very fast. We're talking within the first minute, 30 seconds to a minute. We're warming them up. We're going straight to airway. Okay, so we have to maintain the body temperature of the newborn infant. So hypothermia also will lead to hypoglycemia, and that all leads to respiratory distress. And so, as I said, decline in the baby. Okay, remember that heat is lost in the infant very quickly. As soon as it's born, the baby is wet with amniotic fluid and blood and body fluids. So the newborns do lose a lot of heat really quickly. Make sure you understand also that the babies lose the most heat from their head the fastest because their head is very large in comparison to the rest of their body. So it does lose heat really, really quickly. Okay, we'll talk about mechanisms of heat loss that you'll need to know about in a couple of slides. So the key here is as soon as the baby's born, as soon as that cord is cut, we have to do one of two things. We have to either do skin-to-skin contact, which we also refer to as kangaroo care, or we have to take the baby immediately to the warmer that should be pre-warmed and get it on that warmer. Okay, those are the first two things we do. Now, if the baby is not in obvious distress as soon as it's born, we can do skin-to-skin contact, and studies have shown that the babies really warm up just as quick with kangaroo skin-to-skin contact that they do on a warmer, which is really interesting. Now, that is how God made it, for you to put skin-to-skin contact and the baby warms up, because the mom's temperature will warm the baby up. But it has to be skin to skin, okay? If the baby is in obvious distress and it's not breathing, we would not leave it skin to skin because we would need to do further interventions. We would take the baby immediately to the warmer, and we would, the first thing we do is dry the baby off because we've got to thermoregulate. So we got to get these fluids off of the baby. So that is our very first step, is to dry the baby off, okay? So what happens, the reason you get hypoglycemia is because the babies, what they'll do to increase their temperature is they'll increase their metabolic rate, and that will decrease their glucose levels because they'll use all their sugars or glucose trying to get their temperature up. So hopefully that makes better sense to you when you think about that. They're very small. Think about it. Their body surface areas are small, so they have to work really hard to keep their temperatures regulated. They have been in this incubator, so to speak, for 9 months or so, and they have been in a warm 98.6 average temperature environment. Suddenly, now we are in this 70 something degrees temperature environment, and they have blood and body fluids on them to top that off. They're at a huge risk for hypothermia, which leads to hypoglycemia, which leads to respiratory distress, and then the baby declines. So that is the first thing we got to take care of. So if you remember that thermoregulation is your number one nursing intervention when you are working in labor and delivery, or anytime you are birthing a baby. If you birth a baby on the side of the road, which could happen, I have had students that have had that happen before. I'm sorry about the loud car next to my house. I do not know why they have to have mufflers so loud, but they do sometimes. So if you're birthing a baby somewhere in an emergency situation, it happens, grab something. Could be a shirt, clothing, a blanket if you have a blanket. And you're going to want to wrap this baby around, and you're also going to want to put something on this baby's head really quick. But before you wrap the baby, you're going to need something to dry it off. Get these wet fluids off of the baby, okay? So that's pretty much that part of it. They may, as far as urinating, it's possible they may not urinate for 24 to 48 hours. So that is really something to think about too. You can't always expect them to have urination right there in the delivery room. But their first void is always documented. If they do void in the delivery room, we do document that on the delivery record. There's a record for delivery that has all of the infant things on it too. The meconium is usually passed within the first 12 hours after birth. So remember, meconium is their first stool. It's black and tarry looking. Remember, we talked about it in Unit 3, that meconium passed in utero is usually indicative of some type of fetal distress. Sometimes they just poop for no reason, but we usually, if we see meconium stained amniotic fluid, we usually think about there's probably been some kind of distress. We assume that. And we also want to be very careful when the baby's born because they could get aspiration, meconium aspiration. But meconium is a normal first stool for a baby. And if they haven't had that in utero, which hopefully they haven't, you will see that first stool and it'll look black and tarry and always should be documented. Okay. They do like the babies to have their meconium before they are discharged from the hospital, just to make sure there's no defects in the GI system. Okay. Another thing that's done right in the delivery room, and this is a mandatory thing for every hospital, every facility, wristbands are always applied in the birthing room. Okay. So what the wristbands are comprised of is usually there's 4 bands. There's a band that goes on the baby's wrist. There's a band that goes on the baby's ankle. There is a band that goes on mom. And then there's a 4th band that's used for whoever she wants to have the band on, a significant other. Now, this band has to be put on in the delivery room. So if that person is coming later, you don't save that band. That could be very dangerous. So that band has to be cut up in the delivery room if there's nobody else in there to put it on. That band is just a courtesy for that mom to say, well, okay, that person has the right to go to the nursery and pick up my baby. And so it's connected with the baby. These bands are very special in that they have a special number on them. In addition to the medical record number, they also have special numbers on them that all match. They should all match. It's the nurse's responsibility to make sure all 4 of those bands match and that they are put on in the delivery room. They cannot be saved or taken out of the delivery room without being put on someone. Okay. Also, these bands, most of the times they'll have some kind of sensor on them. It's a sensor that will detect if the baby goes near any doorway or goes out a doorway, and the alarms will go off. It's like connected to the alarm system. Okay. Some facilities, they have this sensor on the umbilical cord, so that someone couldn't just cut the band. Some facilities have bands that if the band is cut, the alarm will go off. So there's different grades of these different alarm systems. So it just depends on what that facility has. Okay. It's very important that nurses are very cognitive of infant identification. And when you put these bands on mom, and I want you to remember this for our OB lab, when you walk in the room, when you are in the delivery room and you put the bands on mom, you should be teaching her, okay, these are your bands that match. These numbers, see these numbers here? I've got one on the baby's ankle and one on the baby's wrist. These numbers all match. So anytime someone brings your baby to the room, if your baby leaves the room, you need to make sure they check all these numbers before they leave the room to make sure that you have the correct infant. Okay. Make sure you also teach infant security to them. Make sure that you keep your baby in the crib on the opposite side of the where the doorway is. Make sure you don't leave your baby unattended. Don't go to the bathroom and leave the baby unattended. Leave your door open. It's okay to do that. Make sure you know every person that comes in and takes your baby from the room. A lot of hospitals will have an identification badge on that has some kind of ID that shows that they work in that facility. Like I worked in one place that had a stork on it, and that's how they knew. I also worked in another place that we were given a daily password, and the patients were given that password, and nobody could take their baby unless they were able to verbalize that daily password. It's a little bit more cumbersome, but it works. So code pink is usually the code that is called for an infant abduction, and it does happen. It's rare because of all these security systems that have been put in place, but I'm sure a lot of you have seen movies and things where it's happened, and because it really has happened. People will come in and steal a baby, and hospitals usually are required by Joint Commission to have code pink drills, and we will barricade all doorways. The whole hospital goes under alert and lockdown, and we'll usually have like a baby doll and a big purse. I've done it before. I've been the one on the elevator taking the baby in a big purse down the hall, and they're calling code pink overhead. And it's really interesting and amazing sometimes to see people just will pass you right on by with this big, huge bag, and you've got this baby stuffed in it, and there's a code pink being called. So that's really, really interesting. But the more drills they do, then people get more used to what they need to be doing if they see someone with a big bag and there's a code pink called. They should always stop that person and question them if they are walking out with a big, huge bag. Okay. Also, there's a gestational age assessment that we do, but it's usually not done in the delivery room. We will go over that more in newborn care, but that is just to see if the physical signs and assessments of the baby match up to their gestational age. Okay, so there's a lot of different little tests for that we'll look at. Okay, we get a rectal temperature normally. Now, some places aren't doing rectal temperatures anymore. I'll just tell you that because of the danger of the damage to the sphincter. Some are just doing axillary temperatures, but there needs to be a temperature in the delivery room. Respiratory rate has to be done and heart rate. Okay. For infant resuscitation, if the baby is in distress and you have warmed the baby up, dry the baby off, remove that wet blanket. Never leave the wet blanket underneath them. They're on the warmer, and you look immediately. This happens within like 10 seconds. The baby's not breathing. Then you have to do airway breathing for them. So with a positive, we call it PPV. So we do that with a bag and mask that's to 100% oxygen, and we make sure that, and 5 liters is usually what we set it on, by the way. And we do the bagging, and we usually will do that for about 15 seconds and stop and see if they're breathing. Usually the babies will breathe after 15 seconds on their own of that positive pressure ventilation, but sometimes they don't. Okay, so for 15 seconds, we're doing positive pressure ventilation. Remember, babies breathe fast, so we're having to do like 40 to 60 breaths per minute. So it's pretty fast with the bag and mask for a baby if we're having to do that. But what has happened here is, do you remember that the babies have a fetal circulation where it bypasses those goes through the shunts and bypasses the lungs. And so the lungs are not inflating during utero. Okay, but as soon as the baby's born, and you've probably seen a baby, if you've seen a delivery, they take that big and they cry really hard. That's because they're trying to get enough pressure into their lungs to make their alveoli expand and their lungs expand and be able to take that breath and those shunts close. Well, if babies don't have enough pressure, maybe they're not getting that first big deep breath and cry, then they may not expand their lungs and then they're going to go into respiratory distress. So that PPV, or that positive pressure ventilation, will give them that extra pressure to help them expand those lungs and start breathing. That's usually all it takes, is with the PPV for 15 seconds, and babies will breathe. Babies that have been in more chronic distress for a longer time may have to go further. So as soon as you get done with that PPV for 15 seconds, then you check a heart rate. Okay, and you can do that either with the umbilical cord, or you can do it with a little tiny little neonatal stethoscope and listen to the apical. Now, this is where it's different. We normally listen to a newborn with our daily assessments for a full minute, but for resuscitation in the delivery room, we're going to listen for 6 seconds. That's all. We're going to listen for 6 seconds. We're going to either listen or palpate the umbilical cord for 6 seconds, get that pulse rate, and we're going to multiply it times 10, okay, in our head. So let's say if we got 10, we know it's 110. So anything over 100, we don't have to worry about it anymore. So we don't have to do anything else. If it was less than 100, if we have less than 100 on their pulse in 6 seconds, so less than 10, then we would have to continue positive pressure ventilation. Even if they were crying and kind of whimpering, if their heart rate is under the 100 or under 10 in 6 seconds, we would continue with positive pressure ventilation. Okay, so 2 reasons to continue with positive pressure ventilation are, number 1, it's less than 100 beats per minute in 6 seconds, or 2, they aren't breathing. Okay, or they aren't breathing good enough. They're really wimpy breathing. Okay, those are the 2 reasons we would continue PPV. Okay, but if our heart rate is less than 100, but it's above 60, we don't have to do chest compressions. If it's less than 60, then we got to do chest compressions and we have to do PPV. So we have to have 2 nurses there to do both, okay? And so we usually do 5 compressions to 1 ratio of breathing. So it would be, we usually try to do 90 repetitions of breathing and cardiac compressions in a minute. So it's like we'll do 1, 2, 3, 4, 5, breathe. 1, 2, 3, 4, 5, breathe. 1, 2, 3, 4, 5, breathe. Okay, that's pretty much in a nutshell what NRP, neonatal resuscitation, is. We do that for about 15 seconds together, us 2, and then we check the heart rate again. If the heart rate is still under 60, and obviously we've already called respiratory by this point, pediatrician's on the way. After that point, the pediatrician's really going to want to intubate the baby, and we're going to want to give the baby epinephrine, and it goes further. But I just wanted you to understand those first steps that are involved there, okay? But like I said, normally the PPV for 15 seconds does the trick to give them that enough pressure to open up the airways and they can take that big deep breath. Okay. We also do a weight and measurement once the baby is stable. Moms and dads always want to know what the weight is. So we'll do that as quickly as we can. A scale is in the room. And we will put a clamp on the cord. The doctor has cut the cord, so there should be a clamp on the cord. Some hospitals will put like a betadine, we call triple dye, on the cord, but a lot of hospitals now are just leaving it plain, and there's no special care to it. It has to be done other than keeping the diaper underneath that cord, and it'll dry and fall off. Okay. Okay. So newborn phases that they go through, which you do need to know these phases. The phase 1 is 0 to 30 minutes, okay? And what happens is the baby's transitioning from fetal circulation to normal outside the womb circulation. So this is what happens in phase one, the first phase, for the first 30 minutes or so, you'll have tachycardia that's starting to get back to normal because the baby's heart rate's having to go fast for it to kind of normalize everything, and those shunts are trying to get completely closed. You'll have irregular respiration. You might even have some rales or wheezing present, some crackles present. The babies in the very beginning, in that first 30 minutes, they're usually so alert. Their eyes are huge. They're very alert. They have a really brisk Moro reflex, and that's just where you take the baby's hands and you kind of pick the baby up and let the baby drop, and the baby has that return, his arms return back up. That's the Moro reflex. Tremors are normal. Crying is very normal. Increased motor activity and big response to light. They usually don't have good bowel sounds during that first 30 minutes. Things haven't started moving through there yet. In that first 30 minutes, the babies are so alert. It's a really good time if you can to get them breastfeeding because they're so alert. They'll usually just latch right on and do really good, and they'll be, oh my gosh, this baby's breastfeeding so good. Well, then later on, the babies get so sleepy and they don't breastfeed so well. So we try to do that within that first 30 minutes, but that's why. The second phase is 30 minutes to 2 hours. The baby begins to have decreased motor activity, rapid respirations up to 60, normal heart rate, because their respiration shouldn't be above 60 anytime. Their heart rate normalizes and they start to have bowel sounds. In the third phase, which is 2 to 8 hours, they have abrupt, brief changes in color and muscle tone. They have presence of mucus, oral mucus, and we always use a bulb syringe. Always go in the mouth first and then the nose when you suck content out. I always remember that by M comes before N in the alphabet, so mouth and then nose. So you go into each nostril also. Responsiveness to external stimuli is there, and the infant begins to stabilize and suck and swallow better and is ready for feedings again. So during the first 2 hours, after the first 30 minutes, they may not breastfeed at all. They may be so sleepy. 2 to 8 hours is a good time to feed also because they'll be waking up. So these are mechanisms of heat loss that you need to understand. You've got to memorize these because you're going to need to know these. But evaporation of liquids from the skin. So evaporation is one. Conduction is caused by direct contact with a cold surface, which is why we don't want to put the baby on a cold surface. We want to put it on a warmer. Okay, that's called conduction. Convection is caused by heat drawn away from the body by drafts. So if it's a drafty room, heat can be drawn away from the baby. You would never want a fan in there or anything like that. And then there's radiation. It's caused by being near a cold surface. So even if the baby was close to a cold surface, so maybe there was a cold air conditioner or something right next to the baby's crib, that could radiate and cause the baby to have some hypothermia. Remember I told you that the cold stress or hypothermia can lead to hypoglycemia and then can lead to respiratory distress? This is true for all newborns continuing on even past the delivery room. So we keep a hat on the baby, we keep the baby snuggled, warmed up in a blanket, we bundle them up like a little burrito. That's what they look like. We even put their little hands inside the blanket. Everything is very warmed up because we do not want the babies to be cold stressed. There's a table in your book, table 9.3. I believe it's on 228. I don't have my book right here. That it's nursing interventions to prevent heat loss in newborns. So those are some interventions you will want to read about. Okay, continuing, as I said, we do the gestational age assessment that we will talk about later. Just know that there's a gestational age assessment that has a lot of different assessments on it, and just a couple of examples of what that assessment includes. One thing is like vernix. So vernix is like the cheesy substance that can be on a baby's skin. That is more common in preterm or early, okay? So it could be that the weeks of gestation show she's 40 weeks, but the baby's covered in vernix. Also in lanugo, which is the hair that covers the baby, those are signs that the baby's not as old as what it looks like she is by gestational age. So that's what a gestational age assessment is, but there's a lot of different tests. Measurements of the head, measurements of the chest, weight, all of these things factor in that we'll talk about later. Okay. So we assess the skin, as I said. There could be peeling. Peeling can mean the baby is post-term, okay? And that happens quite frequently. The ears, if they are folded, do they spring back slowly? That's preterm, okay? Breast tissue, genitalia, and soles of the feet. Those are all part of the gestational age assessment. You can look at those on page 322. You do need to know these different signs that show what they do. Like you need to know that preterm, the ears are going to spring back slowly. The breast tissue, the genitalia, there's things like if the labia majora covers the labia minora, that's more indicative of the post-term baby. So those are things to look at, okay? Creases on the soles. The more creases on the soles, the older the baby is. Think about it, they're in that fluid and they're wrinkling. So maybe that help you remember that. So another thing in the delivery room, we're going to look at the baby's fingers and toes. We actually literally count to make sure that there are 5 fingers on each side and 5 toes on each side. We're going to look at their facial features, make sure we don't see any facial drooping. Remember that when you have the forceps delivery, it could cause facial nerve damage, which you could see facial drooping, and also just an anomaly, a nerve anomaly or something else. You want to look at facial features. If there's a cleft palate or any kind of abnormality. If the baby has any abnormalities in their range of motion, okay, we'll take the vital signs, as I said, and just so you know, it's just like the fetal heart rate. We would expect their heart rate when they're first born to be between 110 and 160. You can try to understand also that the older the baby is, the lower the heart rate will be. So you're going to be more at the lower end of the normal. If it's a 40-week baby, it may be more like 110. Or if it was, say, a 34-week baby, it may be 160 because it's going to be at the higher end of the normal range. So we do want to look at the ranges on that. The temperature, axillary is the most common because we do have the risk of performing perforation of the rectum. And we also take it 30 minutes after their bath and 1 hour after we transfer them to an open crib. Because remember, this thermal regulation thing is the first step and it's the highest priority for the newborn to make sure they don't go into distress. Okay. We can do blood pressure. Every facility is different on that. A lot of places will do all 4 limbs to assess and identify pressure differences. If there's what's called a coarctation of the aorta, and that's just where the walls of the aorta become pinched off or pressured together and they constrict blood flow, we might see a difference in the blood pressures. Okay. So the normal blood pressure for a baby is usually systolic 65 to 95, diastolic 30 to 60, and then respiratory rate should be between 30 and 60. Okay. Weight, as I said, should be taken in the delivery room. Okay. And we will do not only pounds, but we'll also record it in grams. Okay. And we put the baby on a clean disposable scale paper to keep from cross-contaminating. We always will keep our hand just above the infant for safety, but you don't want to touch the infant during the weighing because that will skew the numbers. So then we will also do the length, the head circumference, and the chest circumference. So we measure the chest using a tape measure at the nipple line. The head is measured just above the eyebrows. We'll measure all those, and we also measure the length. And we would use that with a tape measure, and it is always, we would measure in inches and centimeters for that. Okay. Umbilical cord care is, again, we delay that for 30 to 60 seconds because it gives the baby more what I meant to say is the doctor sometimes, if he delays clamping of the cord for 30 to 60 seconds before he cuts the cord, it's been proven to give the baby more iron. Now, a lot of doctors don't do that. They don't have the patience to wait 30 to 60 seconds. But if you work with midwives or naturalistic, holistic, you'll see more of that. So the physician applies that plastic clamp and the skin and near the skin, and the cord is cut just above the clamp. And we looked for the cord vessels. So there's 3 vessels. You got to remember this too. Remember the acronym AVA, AVA, and that's 2 arteries and 1 vein. Okay. If there's a 2-vessel cord, it could be associated with internal anomalies, like such as genitourinary problems. So that's something to definitely report to the physician if you can only see 2 arteries or 2 vessels. Okay, and you can see a distinct difference in how they look with the arteries and the veins. They look a little different on the cord stump. Okay, so obviously we already talked about cord care. We're going to teach the mom to keep the diaper below the cord and to look for bleeding, look for signs of infection. There's not really any special thing she has to do other than making sure, unless the doctor orders it. The other thing we tell her, you can't do tub baths and immerse the cord in water until the cord completely falls off. That's the pretty much the general practice on that. There's a skill in your book on page 231, skill 9.6. Hopefully it's on 231 for umbilical cord care, but it is in your book. So make sure you read over that. Some places will tell her to clean the cord with alcohol at every diaper change. And some places will say, don't worry about cleaning it at all. Just watch for signs of infection and it will dry up and fall off on its own. Okay. She should report anything she sees that's abnormal with the cord to the physician. Okay, we talked about infant security already in pretty much depth, but this is kind of what it might look like. The band may look like this here, and there's a number here. This is the number that may match all the bands together. So all of them would have a printed number on them. I think we talked already enough on infant security and what you need to teach mom and how you put the bands on in the delivery room. This is a picture of a sensor, what it might look like. They all look a little different, but that would be a picture of a possibility of what a sensor might look like. Okay. Where it could become a problem, especially if you are working with someone who has dysfunction going on between the dad of the baby and the mom. He may not have rights legally to come in there, and those are usually the kind of incidents that you'll see if it's going to happen, that the baby's taken by someone. It has happened by other people too before, but a lot of times that's what happens is he feels like he has the right to have the baby, so he could take the baby. So gotta really, really be careful. Okay, we talked about hypoglycemia. So hypoglycemia can happen very quickly with an infant. So that's something to really watch for. Their brain does depend on glucose for metabolism. Okay, the infants at risk for hypoglycemia are preterm and postterm. Diabetic mothers, large for gestational age babies. Those are like usually your babies over 4,000 grams or over 9 pounds. Macrosomia, remember that word from before? Fetal macrosomia, they're greater than 4,000 grams or greater than 9 pounds. They're at more of a risk for their blood sugar dropping, so which is hypoglycemia. And then remember, then they're more at risk for respiratory distress. So that's kind of goes hand in hand if they get hypoglycemic. Small for gestational age babies or intrauterine growth retarded. What that means is the baby's full term, 40 weeks, but the baby's only like maybe 4 pounds. So it's full term, but it just didn't grow big enough. So those babies are also at risk for hypoglycemia. Babies that are asphyxiated, meaning they haven't had enough oxygen, they're more at risk for what we call cold stress, which leads to hypoglycemia. Infants whose mothers took ritidrine or terbutaline to stop labor, interestingly, are at risk for hypoglycemia. Okay, so those are things we have to look for. So again, the brain does depend on glucose for metabolism. So the infant is fed formula or breastfed if their blood sugar does drop below 40. So 40 is the key number for what their glucose should be at least. It's 40. If they're less than that, we do want to feed them formula or have them breastfeed. Okay, breastfeeding should start immediately. That will help solve some of that. Okay. So glucose less than 40, as I said, the high risk ones, the infants that are cold stress, the body uses the glucose stores to generate heat. Okay, so we got to make sure we don't have any cold stress going on. We have the baby nice and bundled and warmed up. So we will do a glucose evaluation within 1 hour after birth if they are high risk, like the ones I just mentioned. We stick the heel, that's what's stuck for a baby to check their glucose level. And there's a picture in your book, should be on page 219, that shows a picture where the heel is stuck. Okay, so it's like the outer portion of the heel. Okay, babies do cry when they get their heel stuck. They don't like that. And then they will take that just like you do a glucometer on an adult with their finger. You just put it on, use a glucometer machine and check their blood sugar. Now there are babies that say they have a super low glucometer level, like say it was 20 or less. You may not want them to suck on a bottle because of the fact that that's going to increase their metabolic rate and it's going to cause their blood sugar to drop even more. So in those cases, sometimes they'll put an OG tube down their mouth into their stomach and give them sugar that way. So formula or sugar water, whatever the doctor wants you to do with that. I will tell you, colostrum has a lot of sugar in it. It's a natural sugar. God made it that way. I've tested it before when I had a low blood sugar on a baby and their blood sugar shot right on up because it's full of sugar. It's got a lot of great sugar in it. And so it's really good for the baby. So breastfeeding is good. Pediatricians get very squeamish about giving them the chance to breastfeed. Understandingly so, if their blood sugar is low and it's critical or whatever, they are scared that the baby won't latch on or breastfeed well and then their blood sugar won't come up. So most of the time pediatricians are just like, give the baby some formula to get that blood sugar up. Okay, infants that have signs and symptoms of hypoglycemia. You do need to know these signs or symptoms. I will tell you that. They will become jittery, poor muscle tone, sweating, lethargy. Sometimes they could even have seizures. Respiratory distress. Remember I told you they'll go into respiratory distress? High-pitched cry. That's important to remember that one. High-pitched cry is very much a hallmark of hypoglycemia. If you see a baby that has a high-pitched cry, hopefully that nurse is saying, let's check the blood sugar. A poor suck is a lot of times indicative of that, and a low temperature sometimes because, right, that can lead to hypoglycemia that we talked about. Okay, let's talk about what's called a newborn screening test. So a newborn screening test, there is a lot of different diseases that the newborn screen tests for. It's done on the day of discharge because they try to wait until the baby has a good feeding established so that they can see how it's done with all the nutrients with these different screenings. One thing that's real important to make sure they have good feeding established is phenylketonuria, also called PKU. It used to be called a PKU test, but now it's called newborn screening because it screens way more than just a PKU test. Okay. PKU is a genetic inborn error of metabolism. It's detected the first days of life with appropriate blood testing. But the baby has to have eaten something. That's what causes them to spike their PKU. The absence of deficiency of an enzyme that is responsible for processing essential amino acid phenylalanine. Okay, so if these formulas have phenylalanine in them, the baby drinks the formula and it shows their PKU that they have positive phenylketonuria in there, then they are going to have to be on a very special diet. This I'm sorry, phenylketonuria, that's a big word, um, can cause brain damage if the numbers are not regulated. It can cause brain damage. It can cause a lot of neurological defects for the baby, for the child. So growing up even, they have to be on a special diet because there's a lot of foods, including things like peanut butter, artificial sweeteners. There's a lot of foods that have artificial sweeteners that they have to avoid if their PKU comes back positive. Okay. Another test that they could do is with the newborn screen is hypothyroidism. That's one that is detected in the newborn screen. Sickle cell disease can be detected. Maple syrup urine disease. These are just a few, okay? And maple syrup disease is also a genetic defect. It's an amino acid metabolism disease that causes acidosis, okay? They can have central nervous system symptoms with this, and the urine might smell like maple syrup. It's actually called maple syrup disease. Okay, let's see if there's anything else on that. Okay, this is just a picture of a mom giving a bath for the first time. Maybe not for the first time, but that's a bigger baby. So the babies usually love the baths if they're a little bit older. In the beginning, babies will cry when they get their bath because they don't like that water. Even though it's warm water, they don't like it too much. But my experience is when you take the warm water and you put their head under it, just their head, obviously you don't put their whole face under the water, but just their head part, they stop crying. Like they love getting their hair shampooed and they love getting their head warm. And it's just really cute. They'll be screaming and you put their head under there and they just stop crying. So it's really cute. Remember, the umbilical cord hasn't fallen off. She cannot immerse in water, okay? But there's a lot of baths, baby bath products that they can buy, like this little bath chair that can go into the tub that helps a lot with mom. Safety is really important to teach her on bathing. Never leave the baby unattended in the bathtub. The accidents have happened that way. That's just one. Making sure the temperature of the water is not too hot. So feeling it with your elbow is a good way to do that to make sure it's not too hot for the baby because it might not feel hot to your hands. You're used to hot water, but it might be hot for the infant. Okay. So with skincare, after the temperature stabilizes, all amniotic fluid and other secretions are washed off with that first bath. And we don't want to try to get rid of all that vernix, that cheesy-like substance, if there is that on there. It does have a protective function, so we don't want to scrub it off. Okay, we're just washing the baby gently. Clear water only. Babies can be very sensitive to soaps. That's what your book says. I will tell you that a lot of hospitals use baby soap, and it's usually safe because they use the no chemicals, no added anything to these baby soaps. And that's okay, depending on the function or the policies of the facility you're in. You always want to wear gloves until after that first bath. You would want to wear gloves for that first bath. After that first bath, you don't necessarily have to wear gloves to give the next bath. Okay. So next we're going to talk about bonding and attachment. And remember that dads do bond also, not just the mom. It is real important with bonding with the mom. I will tell you, I've seen a lot of dysfunctions with bonding. It's sometimes there's no bonding there. And it's concerning when you see that she's not even interested in her infant. We talked about teen moms. Sometimes I see teen moms that are not bonding with their infant. They're not interested. Or you may just have a very self-centered mother that didn't want to be pregnant in the first place and she's not bonding with her infant. And sometimes you have to call social services because you've got to intervene for this baby. Remember, this baby is your patient too. So you're going to have to intervene for that infant. Okay. So, as you know, bonding is just a strong emotional tie that forms after birth. So, when that baby's born, you should usually hear mom saying, "Oh, he looks just like dad," or "Oh, look how cute he is," or "He looks just like me. He's got my eyes. How many fingers and toes does he have? How much does he weigh? Oh, we have a boy. I'm so excited." Those are the kind of things you should hear. Or if you don't hear anything and there's no oohing and eyeing, it's just like they're not even interested. They're not asking you any questions. They don't want to hold the baby when you bring the baby to them. You have a problem. Okay. Nurses should promote these processes. You try to promote them. Okay. You can reaffirm what they're saying. Oh, yeah, I know. It was so cute. Baby's so cute. Whatever. Just reaffirm them and try to encourage that bonding. And then, as I said, you may have to call social services if you don't see that bonding taking place. Okay. Documenting is really important on how bonding is. It's part of your nursing assessment. So you want to document that both parents are bonding with the infant. And if not, you document that you did call social services. It may or may not help, but you're doing your part by calling social services, calling who you need to call. Okay. Um, Therapeutic communication becomes really important in these cases too. You as the nurse might be able to find out why they're not bonding. Maybe it's a reason you don't even think could be true. Okay. Maybe they're worried about something else. Maybe they're worried the father won't accept the baby. There's so many things that could come into play. So therapeutic communication, especially one-on-one with this patient, if you see this happen, try to get them one-on-one and try to do some therapeutic communication with them. Okay, a full assessment is done on the mother and the infant every shift. Okay, feeding and elimination patterns should be noted. Teaching is an important part of mother-infant care. Teaching's huge in mother-baby care. It is one of the biggest things in there. You're teaching on how to take care of the infant, how to take care of herself, how to teach dad to do things. You're teaching how to give the bath. You're teaching how to feed. Could be breastfeeding. You're having to assist with that. Pain control. There's just so many things you're teaching. Home care. What are you going to do with the baby when you get home? How are you going to care for the baby? These are important safety tips. When you're going to go back and see the doctor. It usually takes at least an hour to do discharge teaching on mom and baby when they're leaving the hospital. It's a big teaching area for sure. Most hospitals have TV on in the rooms that have special channels that they can watch before they go home on infant care and mom care that you can have them watch, and we'll teach them a lot too. You teach them how to use that bulb syringe when the baby has mucus in the mouth first. So when you use a bulb syringe, what you would do is have it open. Okay, then you squeeze it when you get in there. So you would do like put it in there open, put it in the back of the throat, and squeeze, squirt that out, throw that out, and then you would do the other side of the throat, squeeze, throw that out, have it open, go in each nostril the same way, mouth and then nose. And you're teaching the mom that too, and always keep the bulb syringe right there in the crib with them. Infant positioning to keep the airway open. We do not recommend that they put them on their stomach anymore, just always on their side or on their back. Okay. Temperature maintenance of the infant, we teach them that, keeping them warm. How many voids to have? Voiding is really important to teach because they should have 6 to 8 wet diapers a day. If they don't, they're not eating enough. That's a big cue for breastfeeding. So moms that are scared to death babies aren't getting enough milk, you can reassure them if your baby's having 6 to 8 wet diapers a day, your baby's getting enough through breastfeeding. So don't worry because they can't see how much milk the baby's getting through breastfeeding. So that is very scary for them a lot of times. Okay. Changes in stools. The first meconium stool, then it goes into a transitional phase. It changes colors and consistency. And then we will talk about breastfeeding and formula feeding. It's totally mom's choice on whether they want to breastfeed or bottle feed. So we do try to encourage breastfeeding. The American Academy of Pediatrics does recommend breastfeeding for at least the first 6 months to 1 year of life. So it's got very large amount of immunities in it for the baby that the baby can have through passive immunity. Colostrum has so many nutrients in it. It's just the perfect food for the baby. So we do want to try to encourage that. Of course, it's good if it's going to cause problems with mom and she's just totally unhappy breastfeeding. We don't force it on her. We let her bottle feed. Many babies live normal, healthy lives bottle feeding, and it's not the end of the world. We just know that it's better and more ideal if she can breastfeed. We teach her signs of illness to report. If your baby's temperature axillary gets over 100.4, you need to call the doctor. Okay. And then, of course, follow-up appointments. These are just a few of the things we teach. We teach car seat safety. There's just a big long checklist that we go through. Okay. This is a picture of meconium, what it would look like. See, it's very black and very tarry. Now we're going to talk about breastfeeding. Okay, it does have many advantages. There is a teaching in your book, Table 9.4, should be page 236. As we said, breast is best. There's benefits on page 234, advantages of breastfeeding. Be sure you read that because it's got a few of the things I've talked about and other things as well. Know that prolactin causes the production of breast milk. It is in high amounts during pregnancy. Remember, that's the hormone responsible for milk production. Okay, that's something you need to remember, that prolactin is the hormone that is responsible for milk production. Okay. Oxytocin causes the milk to be delivered from the alveoli. We call that a letdown reflex because mom can feel that milk being come down into the alveoli. Okay. It's a weird feeling. It's just like a sudden burst of pressure is how you could explain it. The breasts fill with milk about 3 days after birth, and you have colostrum before then. If the milk is not released, then the secretion of prolactin stops and the breasts return to pre-pregnant size. So that's what's going to happen if she's not breastfeeding. Now, she might have severe breast engorgement until that milk dries up if she's not breastfeeding. So again, teach her to wear a good supportive bra, not be facing the shower and have warm water run over it, things like that. Nipple stimulation by the infant when sucking causes the release of oxytocin so that milk is delivered to the newborn. Okay. Very little milk is usually stored between feedings. Most of it is produced as the infant nurses. So the composition of the milk changes from the beginning of the feeding until the end. There's two parts to the milk. Foremilk is the first milk, and it's more watery and quenches the infant's thirst. This is when the baby first starts breastfeeding for that feeding. There'll be foremilk. It's like more watery. You want them to breastfeed long enough to get to what's called the hind milk. It's the latter milk. It's higher in fat content, and it helps satisfy them more. So if they don't nurse long enough, then they might not get satisfied. Okay, that is something that we can teach moms who are having fussy babies. They're breastfeeding and they're frustrated to no end because their babies are not happy, but they're breastfeeding them. We can definitely teach them, okay, we need to make sure you're feeding long enough on each breast to get to that hind milk, and the baby will be more satisfied. Babies, we say, look like drunken sailors when they're satisfied. They really do. They're just like, they look drunk when they get done feeding, and they're satisfied. So really cute, and a lot of times you have to wake them up to try to offer them the other side. Most of the time, it's not timed on each side. You let them feed as long as they want to on one side, and then the next time you offer them the side you left off with. Okay, so you want to always offer them. So let's say you start on the right side and you let them feed. They go into that drunken sailor mode, so they get the hind milk. They're satisfied. Then you want to stimulate them and wake them up and offer them the left side. The next time you feed, you'd want to start with the left side because that's going to be your fuller side. Okay, so we teach them that too. Okay, remember that it does help stimulate oxytocin and control bleeding. So breastfeeding in the immediate part of labor and delivery in the delivery room is really helpful with that as well. We're also giving them Pitocin through their IV to try to shrink up the uterus also right after delivery. Some cultures use galactagogues, and it's like a breast milk stimulator supplement. Some of the most common include beer, rice, sesame tea, And we have to remember to be culturally sensitive. As far as positions go for breastfeeding, the mother can lie on her side to breastfeed, and the infant and mom in that case should be chest to chest. To get the baby to latch on, the mother should brush her nipple across the baby's lip, make a C with her breast. And the infant will usually open their mouth wide, and the mother should place her areola in the baby's mouth as much as she can. Now, some moms have too big of areola for it to go in, but we try our best to get all of it in. The infant's lips should flare outward if they're properly latched on. Each infant has their own sucking pattern. Noisy sucking could mean that they aren't latched on properly, and she's going to end up with cracked nipples and sore and give up on breastfeeding. Removing the infant from the breast is important that she takes her finger to kind of detach that latch, because these babies, man, they latch on tight. And if you just pull them off, it's going to cause injury to that breast and that nipple area. So some signs that the breastfeeding is successful: the infant appears relaxed after feeding, like the drunken sailor. The infant has 6 to 8 diapers a day, passes stool several times a day is pretty typical for breastfeeding. And the breasts feel full before feeding, but soften afterwards. Okay, there's essential factors in breastfeeding on page 237, box 9-1. You'll want to read that too also. This is a good little diagram for you to look at on your slides. It's also in your book on page 235, figure 9-9. So you see that we have it starts with the hypothalamus. We have the releasing hormone through the posterior pituitary. And then we have the prolactin causes the milk production, and the oxytocin causes the milk ejection. Okay. Okay, so remember that the milk production is the prolactin, the oxytocin is the milk ejection. Okay, this one just shows some different positions we can use for breastfeeding: the cradle hold, the cross cradle hold, the football hold, the lying down. So honestly, the football hold and lying down are real good for C-section patients that have an abdominal incision, so it's going to hurt more if they're lying in the other ways, because it's going to like kind of put pressure on their abdomen. This is in your book too on page 237, figure 9-10. Let's see, and then we have, see, that's cute. Look how it's all snuggled up there, breastfeeding there. And mothers get really good at breastfeeding to where people don't even know they're breastfeeding. Like they'll put a blanket over them. You can't even tell. So the frequency, normal is every 2 to 3 hours is considered normal for breastfeeding during the early weeks. It hasn't, if the baby hasn't nursed for 3 hours, the nurse should gently stimulate the infant and try to feed. This is just when you're getting their feeding established in the beginning. We typically just teach them to feed on demand, and that's pretty much the standard practice. When they get home, just when you see hunger cues, the baby starts rooting, turning their head, rooting, they start acting like they're hungry. If they are crying miserably, they are not in early hunger cues. They are in late phase of hunger cues, and that's not when they want to feed, because a lot of times they won't latch on in that phase. So they need to be taught to look for those rooting, turning their head towards them, things like that, those hunger cues, sucking on their hand. A lot of times they'll do that too. It could take up to 5 minutes for that letdown reflex to occur and for that oxytocin to kick in and the release of that milk. So that she should nurse at least 10 minutes on the first breast at the beginning and then offer the second. They don't swallow much air, so they really don't have to burp much when they're breastfeeding. So be sure you read box 9-2, Recognizing Hunger in the Newborns, 239, and then the proper latch is page 238, figure 9-11. And there's some pumping pictures on 241. So some mothers pump. Some mothers will pump their breasts so that they can go to work. and they can have stored milk. You can freeze the milk and they can take it with a bottle so they can continue breastfeeding. Some mothers will breastfeed when they're home, and then they'll use the pumped milk when they're at work. So it works. It does work. You just have to really, I guess, work a little harder at it, if you're having to work. It makes it a little bit harder because you got to do all the pumping in addition. So you'd have to be pumping while you're at work. And some places are not as accommodating for that as others are. Bottle feeding the infant on page 244. It's important that you understand bottle feeding because it's important that moms know that they should never prop the bottle, and that they should always make sure that there's liquid in the whole nipple part, that they're not having it propped to the point where there's just air going through the nipple, because that can cause a lot more air and colicky babies and things like that. Babies that are bottle fed, they do have to burp. They need to burp because they will get a lot more air. So usually after each ounce, we'll teach them to burp. It is a little bit easier for moms that have a lot of anxiety because they can see how much milk they're getting. That's the difference. It is for some moms considered to be harder because you have to prepare the bottles, and if we're breastfeeding, you can just pick them up in the middle of the night, have sleep, and breastfeed. So it's always there. So that part makes it a lot easier. Okay, there's something called baby-friendly hospitals. So the initiative launched in 1991. It's been around a while by the U.S. Children's Fund and the World Health Organization, and the goal was set to promote breastfeeding. Okay, to be a baby-friendly hospital, it has to meet criteria. So they must have written breastfeeding policy and teach skills to staff. The parents are educated on the values and techniques of breastfeeding before and after delivery. Breastfeeding is initiated in the delivery room if possible, so they would be encouraging that. The newborn is only fed breast milk, and staff encourage feeding on demand. Mother and newborn room in 24 hours a day. No pacifiers or artificial nipples are used. Formula samples are not distributed at discharge, and new mothers are referred to support groups. So they can't be given pacifiers and things like that to babies that are breastfed, and they have to follow all these protocols to be a baby-friendly hospital. Be sure you read communication on page 236, and also read cultural considerations on page 236 as well. Remember, crying is a late sign of hunger. It's a late hunger cue. So remember that rooting and turning their head, sucking on their hand or on whatever they can come in contact with. Those are signs, those are earlier hunger cues. Okay, these are just some of the advantages of breastfeeding. I told you to read on it, but it can lower rates of ear infections or otitis media, respiratory infections, gastroenteritis, UTIs, thrush, diabetes, childhood leukemia, necrotizing colitis, and obesity. And they have proven even that it can influence intelligence in children. 22.3%, I don't know when this study was done, but 22.3% of women in the U.S. exclusively breastfeed for 6 months or more. So I know they're trying to increase that number more and more because of the advantages there. So that we should teach her how to recognize those early signs of hunger. If the baby hasn't been fed for 3 hours, she should wake the baby and try to breastfeed. Now that would be just, like I said, in the beginning when she's trying to establish breastfeeding. Alternating the breasts increases milk production. You're going to see different philosophies on this. The breastfeeding friendly hospitals, they're going to be doing all on demand. So it's very, very dependent on your pediatricians in your hospital. Really it is. And your nurses. If the nurses are not pro breastfeeding, they're not going to be encouraging the patients either. So it just depends. And then you've got the patient's choice, which you always want to honor. You do all the education and you let them make their own choice. That is basically what you're doing. And encourage, if they really want to breastfeed, you want to encourage, and you may see a lot of tears. You may have to call a lactation consultant. A lot of hospitals have that to come in and help them with breastfeeding and things like that. So babies can get nipple confusion. Now, a lot of the Hispanic population like to do both breastfeeding and bottle feeding. That's their culture, and they do it well. But the babies can be prone to nipple confusion, but for some reason they do it well. So I don't complain. If that's what they do and they're fine with that, the more power to them. They're still getting some breastfeeding in, so that's great. Engorgement will happen if enough milk is not being removed from the breast. If the baby doesn't have a good latch, it's not a good suck. The baby becomes irritable and cries and is not getting enough of the milk, or they're in giving late hunger signs and they're not going to feed as well. If they're crying, like screaming and crying, they're not going to breastfeed as well. They should nurse on the first breast for about 10 minutes, and then she should put the baby to the other side. We've already talked about that. Okay. Let's see. Breast engorgement. It's very more common in the beginning before you establish the milk supply. I told you about that before. She can pump if she does have breast engorgement, but you need to teach her. You don't want to do that as a normal practice because remember, the more you pump or feed, the more milk you're going to make because your body's trying to adjust to make whatever milk production you need. So that would only be just a little bit of pumping to get rid of the severe discomfort. She can use cold applications between feedings and heat just before feedings to help with the discomfort of it. Massage can help to soften the breast and express the milk. Another problem that can occur is nipple trauma. If there's not a good latch, she could get cracks, blisters, redness, and bleeding of the nipples. Positioning the infant correctly is the best prevention for that. Warm water compresses or rubbing a small amount of breast milk into the nipples can aid in healing. So it's a very healing thing is breast milk and colostrum. Hygiene is important. Good hand washing. She should wear a good supportive bra, but not too tight. Okay. Flat inverted nipples, we talked about that already before, but we can help her to roll the nipples between her fingers before feeding. That will help. And they also have some nipple shields that will help pull those nipples out. There are special situations that make it a little bit more difficult for breastfeeding, but some moms just want to breastfeed no matter what. So twins or more, there are some moms that are determined they're going to breastfeed. They don't care they're having twins. They can be breastfed together or one at a time. I personally think I would do them together so I don't have to breastfeed all day long. The body adjusts to the greater demand of milk, as I said. It's especially good for preterm infants. If the preterm infant can't breastfeed, she can pump the milk and it can be frozen and they can do gavage feedings in the nursery. Preterm, very preterm. Why wouldn't they be letting them feed from a nipple sometimes? Because that's going to increase their metabolic rate. They're already very small, which is going to cause them blood sugar to drop, which is going to cause hypoglycemia, which is going to lead to respiratory distress. So a lot of times they will just do what's called gavage feeding, which is nothing more than just an oral gastric tube that goes into the mouth, into the stomach, and we feed straight through there. That's a gastro tube, so G tube. Okay, let's see. Um, breast implants are okay for breastfeeding if the silicone is used, and so it's usually not a problem. Um, we do make sure that we look for plastic bottles made of polycarbonate. That's considered safe so far. They're doing more research on that, but we want to make sure that we have safe plastic bottles. And most of the baby bottles now are that PBA free, and so they don't have the chemicals in them. So, but that is something that we do teach though. Um, Storing milk, it's important we do teach that too. So you do need to know this, okay? If they don't use the milk within 1 hour of pumping, they need to throw it away. And that's the same for bottles too. They need to be thrown away. You should not be kept at room temperature over 4 to 6 hours in tightly sealed container. Leukocytes can stick to the glass, but they're not destroyed. In a refrigerator, you can store milk up to 96 hours. We're talking about breast milk here. Um, you can store it up to 96 hours in a refrigerator. In a deep freezer, up to 6 months. In a regular freezer, up to 2 weeks. It can be safely stored in glass or hard plastic containers. It can be thawed in the fridge for 24 hours or by holding the container under warm water to take the chill off. Okay. We do not advise warming in a microwave. It can destroy the immune factors and it can also make really hot spots in the milk, which can cause a really bad problem. Same for bottle formula. You do not want to heat up in a microwave. We teach not to do that. Okay, breastfeeding, nutrition is really important for her, and you need to remember that they need 500 calories or more a day if they're breastfeeding. So additional 500 to what they normally already eat. She needs to drink 8 to 10 glasses of water per day. Some foods will change the taste of the milk or cause the baby to have gas. So commonly, like chocolate, cabbage, beans, broccoli can cause gas in the infant. But honestly, everyone is different. And so she kind of has to experiment with that because there are some babies that aren't going to have any problems from that at all. And then you have some babies that have severe gas from it. Okay. Breastfeeding uses fat stores from the pregnancy to produce milk, and that could help some moms to lose weight. She needs to eat nutrition, though, for to keep up good nutrition for the breast milk. Meat, fish, poultry, eggs, beans, and nuts, so lots of protein, milk, and other milk products. Eat good amount of vegetables, fruits, spreads, cereals, and grains. Okay. Women that are breastfeeding need 20 to 30% increase in vitamins and minerals, double pre-pregnancy needs of folic acid, and 40 to 50% increase in calcium and phosphorus. So she can get these by eating, like she could drink 2 cups of milk a day and eating the protein, a slice of wheat bread, things like that. She can get that through that, but honestly, most doctors are going to say continue your prenatal vitamins after you deliver to make sure she does get all of that. Okay. If she's lactose intolerant, she can eat tofu, soy milk. Ew, tofu. That doesn't sound good, does it? But or soy milk to me, but some people like it, I guess. Canned salmon also is another one. Okay, for weaning, what we do with weaning when they get to the point where mom wants to wean or she has to wean, she can't help it, she has to. We eliminate one feeding at a time. That's the best way to do it. We start with eliminating daytime feedings and just only do nighttime feedings so everybody can sleep. The infant will eventually become less interested in the breast, especially when solid foods are introduced. It is used as a pacifier for a lot of babies, and that's okay. I mean, that may be what the nighttime feeding is for a while. Some babies will do that for a year or two. You know what? It's okay. It's really okay. We don't have to get all culture shocked about that. If people really want to breastfeed that long, that's perfectly acceptable. There's nothing wrong with it. It's just maybe not the cultural norm to breastfeed for 3 years, but there are some moms who do it, and we shouldn't judge. It's always going to be a beneficial, great thing. Um, Now, when they go to kindergarten, they probably should be finished breastfeeding, right? So, breast engorgement will probably occur if she weans abruptly, and then she should wear a good supportive bra, use ice packs, and cabbage leaves help with the discomfort. And it's weird, but they do really work. Sulfur in the amino acid called methionine acts as an antibiotic and an anti-irritant. So the cabbage has antibiotic and anti-irritant factors in it. Okay, you don't have to remember what amino acid it is, so I don't even remember that. But you just need to know that it does, help with an antibiotic effect and anti-irritant. So it's really helpful with that. This dilates the capillaries and acts as a counter irritant and relieves the engorgement and inflammation, allows the milk to flow more freely. Okay. Okay, so for formula feeding, common formulas are available. Very common formulas are available. There's even some that are the babies that have PKU positive, or they're milk intolerant. They have all kinds of different brands of formula. They have ready to feed, they have concentrated liquids, or they have powdered. Over dilution or under dilution of concentrated liquid can cause serious illness. I don't really like the powdered because of that. I would just as soon use the ready to feed because they have exactly what they need in them. And so formula is designed for is digested slower than breast milk. I want you to understand that. So they're more prone to constipation and things like that. They do swallow more air. Any leftover formula should be thrown away because microorganisms can grow pretty quick. The bottle should never be propped. Told you about that already. And the baby could aspirate that way. Oh, and can also cause cavities and things like that, ear infections. Burp the baby after each ounce. Feeding on demand is also encouraged with bottle feeding babies. Most people feed on a pretty much on a schedule with bottle feeding, but it's a good way to do it on demand too. So again, remember what I said about the nipple. The baby, position the baby so that the nipple is full of formula during the entire feeding. Okay. The mother should wear a good fitting supportive bra continuously to help suppress lactation. Remember that too. Okay. There's a bottle feeding skill on page 244. It's skill 9.7 in case it's not on that page. Okay, we're going to talk about discharge planning in part 3. So I'm going to stop here and then we'll have a part 3 to the lecture.